Hello and welcome to a new RadCast series called OnlyScans, where clinical correlation is most definitely advised as we show you high-yield radiology scans that go beyond the 50 shades of grey. My name is Dr. Mohammed Khan. I'm an FRCR clinical radiologist and also one of the RadCast co-founders. And today we've got a fantastic case that we've called Indent versus Infection, cracking the case of the tricky chest x-ray. So let's get straight into it. So, short history, young male, 2-day history of a cough. What's the diagnosis? What I want you to do is pause the video, look in the description for this video, and you'll see two links. One is to a normal chest x-ray that we want you to use as a comparison, basically a reference, and then also a link to the chest x-ray for this case. So pause the video, have a look. If you know what the diagnosis is, put it down in the comments below. If you know what the differentials are, which is even better in terms of filtering down what the diagnosis could be, then also put that in the comments below. So let's jump in to the case. You'll see two chest x-rays. The one on the left is normal and the one on the right is the case that we're going through today. Now when it comes to any imaging modality, chest x-ray, CT spine, CT aorta, it's all about systematic approach. Make sure you have a system that you use and go through it each time you look at that image. When it comes to the best system, like for example chest x-rays that we're looking at today, what system is best? The answer is there isn't one. It's whatever you feel comfortable with and one that you can reproduce time and time again. Because like I said, and I'm going to reiterate this time and time again, systems lead to success. Some people like to start at the center and work their way out. Others like to start at the periphery and work their way in. It doesn't matter. But whatever you do, make sure you're systematic and you do it time and time again. In terms of what I like to do, I like to start under the diaphragm and make sure there's no free air. Then I like to look at the trachea, make sure it's central, then look at the right and left main bronchus. Then I like to start at the right costophrenic angle and make my way across the right lung field. And then one of the key review areas is the lung apices. Sometimes you can get tumors hiding there, or if it's an apical pneumothorax, it could be very subtle. So unless you're looking at the apices, you may miss it. Once I've done the right apex, I look at the left apex and make my way down to the left costophrenic angle. Now, the thing with the lung fields is that they are a paired structure. You have a right and a left. So make sure you compare the two. So look at the right costophrenic angle, left costophrenic angle. They look similar. Remember, asymmetry may mean pathology. So always in a paired structure, look for asymmetry. Once I've done the lung fields, then I like to look at the hilum, right and left. And then whilst I'm looking at the hilum, look at the heart borders. The right heart border is crisp, which is good. It should always be crisp. And then the left heart border, which is also crisp. One other review area, which is super important, is behind the heart, retrocardiac area, because sometimes you may have masses within the lungs hiding behind the retrocardiac area. Once again, if you're not looking, you may miss it. So I've done the hilum, I've done the cardiac borders, then I look at the bones. Look at the ribs, make sure you look at both the anterior and posterior aspects of the ribs. Look at the clavicles, remember it's a paired structure, so look for asymmetry. Then coming on to the scapula, then of course the humerus itself. So look at the bones. And then make sure to look at the soft tissues. In the axilla here, sometimes you have masses hiding there. So if you're not looking because you're like, oh, it's a chest x-ray, just got to look at the lungs. No, there's a lot of information on chest x-rays. So make sure to look at soft tissues in particular. And then, especially if you're sitting in exams, but also in real life, look at the edge of the film. Sometimes you may spot something right on the periphery. All right. So always make sure you're thorough, but systematic. So now that we've done the system approach in the normal chest x-ray, now let's look at our case in action. So start under the diaphragm. It's clear, no free air. Trachea, it's central, right main bronchus, left main bronchus, looks fine, nothing abnormal there. Now when we come on to look at the lung fields, like I said, right costophrenic angle, now making my way across. As I go up, looking at the lung apices, once again, normal. But like I said, the reason why you have a normal on the left of your screen is to help you develop what normal looks like. So then you can compare normal versus abnormal. Look at all this patchy opacification within the right lung, specifically the right middle lobe. It doesn't appear here. Okay, these are just vessels. All right. This is more hazy, more patchy, just doesn't look normal. All right, and it isn't normal. And we'll come on to that in a second. But like I said, remember, systematic approach. Just because you've seen something doesn't mean you ignore the rest of the scan. Look at the left apex and make my way down to the left costophrenic angle. The left side looks very similar to the normal. So this is what we would say is normal, and it is normal. So now that we've done the trachea, we've done the lung fields on the right and left, we've done under the diaphragm. Like I said, look at the hilum, which is fine on both the right and left. Now let's look at the heart borders. The left heart border is nice and crisp. When I say crisp, I mean you can draw around it. And on the normal, you can do the same. You can draw around the left and then also the right heart border. But now let's try and draw across the right heart border in our case. It's it's basically impossible. Like, where is the right heart border? You can't see it. The right heart border is being obscured. So now already we have two findings on this case. Number one, this patchy haziness, which is located in the right middle lobe, and then loss of the right heart border. So this should already start to make you think of differential diagnoses as to what this could be, which we'll come on to in a second. But remember, don't forget your system. I haven't finished. Don't get what we call satisfaction of search, where you see the pathology and then ignore the rest of the film where there could be other pathologies going on. So like I said, look at the bones. So I'm looking at the ribs. And once again, you start to notice something about the ribs. In the normal chest x-ray, the ribs are very C-shaped, like nice C's. C for like calcium, okay? Nicely shaped C's. But on this case, they look more like figure sevens. Like, it's very different in terms of the orientation and the basic appearances of the ribs. So now we've got a third findings, all right? But remember, look at the rest of the bones. Look at the clavicles. Look at the humerus. Make sure they are fine. And then, of course, look at the thoracic vertebra behind the heart and behind the lung fields themselves. Make sure you've scrutinized all the actual bony structures. Then, like I said, look at the soft tissues, nothing in the axilla and edge of the film, nothing there, nothing hiding just on the periphery of the scans. So we've got three main findings. Number one, patchy opacification within the right middle lobe. Number two, loss of the right heart border. And then number three, a 7-figure shaped appearance of the ribs bilaterally. So if you know what the diagnosis is, or if you know what the two main differentials are, put them in the comments below, and we'll now move on to what those are. So see you on the flip side. So when it comes to this case, and what we were talking about, the three main findings, which were basically patchy opacification in the right middle lobe, loss of the right heart border, and then the figure 7 appearance to the ribs bilaterally, including the anterior and posterior ribs. The two main differentials that you should be thinking about is right middle lobe consolidation versus pectus excavatum. And for those of you that aren't sure what pectus excavatum is, it's a congenital abnormality where you get a concave appearance of the chest wall. It can happen. It's not that common, but it is an important differential based upon the imaging findings that we just went through. So when it comes to right middle lobe consolidation, basically you'll see on the chest x-ray opacification of the right lower zone. You may see a loss or indistinct right heart border, something known as a silhouette sign, which is a really important sign in radiology, and we'll do a separate OnlyScans video on this. You may see air bronchograms, and if in your practice you do a lateral chest x-ray, which is not something done routinely in the UK, you may see a triangular opacification between the horizontal and right oblique fissure. Now when it comes to pectus excavatum, this is where you get blurring of the right heart border. You may also see increased density of the inferior medial lung zone. You may see horizontal posterior ribs and vertical anterior ribs, sometimes known as heart-shaped appearance or the figure 7 appearance that we were discussing. And you may see displacement of the heart towards the left. So what was it in our case? Well, when it comes to our case, you got to remember the two main differentials that should be in your mind when you see this appearance should have been right middle lobe consolidation or potentially pectus excavatum. The history was a young male 2-day history of a cough. Potentially you could have looked at the inflammatory markers. Were they raised? That may have made you think of infection. But in terms of what we see on this chest x-ray is, number one, you see blurring of the right heart border. Okay, not specific for pectus. You also see that in right middle lobe consolidation. You do see increased density of the inferior medial lung aspect of this chest x-ray. Once again, okay, not specifically pointing to you towards pectus excavatum, but it's adding up towards pectus, but not necessarily being definitive. You've got these horizontal posterior ribs with more vertical anteriors. Remember, described as heart-shaped or figure of 7. This is more specific towards pectus excavatum. And then finally, displacement of the heart towards the left. It does look displaced, but once again, you may be uncertain. The key for this case was when we looked at the prior chest x-ray, it was identical to the one that you see on the right side of your screen. So, and that would be very odd that basically the findings just basically map up to previous chest x-rays. And that made us think, okay, could this be pectus excavatum? And then when we looked at more of the clinical history that wasn't provided on the request but was there in the notes, we noted that on clinical examination there was a comment made that this patient had pectus excavatum on clinical examination. So of course, you looking at the radiology in isolation would have given you two differential diagnoses, right middle lobe consolidation and pectus excavatum. But you could have then, number one, looked at prior imaging to try and help you see if this is normal for the patient or if it's abnormal. Number two, correlated with things such as inflammatory markers like CRP, white blood cells, see if they're raised, because that would make you think more of infection. Of course, clinical examination is always useful, and that would have given the diagnosis away. But once again, it's about putting it all together. So always review the previous imaging. This is like a key top tip that we want to share as a result of this module. It really helps in terms of figuring out what is normal for the patient and potentially helping you avoid unnecessary treatment for the patient. Because once we flag this up to the referring clinician, they were like, yeah, this makes sense. This patient does have pectus excavatum on clinical examination. And that is probably why you're seeing what you're seeing on the chest x-ray. So we hope you enjoyed this module. Please leave a like and comment down below if you want any other specific topics covered. We'll try our best. Check out the resources on radcast.co.uk. We've got some amazing courses covering systematic approaches to all the common imaging modalities you may see in your clinical practice. And we'll see you on the next OnlyScans episode. Take care.